And so we were looking at transcranial magnetic stimulation, so non-invasive brain stimulation combined with very high intensity speech therapy for chronic post-stroke aphasia. And so I'll just start by giving a little bit of context about where the study come from and kind of like the rationale of our methodology. I'm sure that this group is very aware of aphasia following stroke, but just to make sure that we're all on the same page. When we talk about aphasia, we're talking about language processing deficits, and this is typically due to left hemisphere strokes because most of us are dominant for language in the left hemisphere, although we know that the right hemisphere has a large role in language processing, but the production side of language is largely left hemisphere. And so following a left hemisphere stroke, you can get multiple types of aphasia. So global aphasia, where both your comprehension and expression are impacted. You can get Wernicke's or fluent aphasia, where you can speak quite fluently, but your comprehension is impaired. And then the focus of this study was non-fluent aphasia, where comprehension is intact, but people just have a very hard time producing the words that they're thinking of. So aphasia is very common following a stroke. It impacts about up to 1/3 of stroke survivors acutely. And this impairment is associated with higher morbidity, decreased mood, and lower quality of life in these survivors. And so what can we do for these folks that have aphasia following stroke? Well, currently the only recommended intervention is speech and language therapy, and has the best evidence out there and typically the best outcomes, and there's not really anything else out there. But even with speech and language therapy, recovery is often quite minimal and highly variable, with about half of those who experience aphasia acutely continuing to have long-term impairments beyond 6 months. So there's obviously a need for novel therapeutic approaches and a better understanding of the neurobiology of aphasia after stroke and how recovery occurs. So to kind of orient why we're targeting certain regions in the brain with TMS, it's important to understand the functional changes that happen after stroke with respect to language. And so this is work done very early on in the 2000s by Dorothy Sauer, showing that functional compensation of language processing is quite a dynamic process. So in the acute phase, you get left hemisphere kind of down compared to normal baseline. And in the subacute phase, you can have some upregulation of left hemisphere language processing, but also you can have uptake of right hemisphere structures that take over some of the language function that helps with small improvements following a stroke. And then long term, what we ideally want to see is that language goes back to the left hemisphere in either recovered or perilesional areas. But occasionally we can have people continuing to have long-term activation of right hemisphere structures, which isn't ideal. And so this idea comes from a few studies that have suggested that recruitment of left hemisphere structures is thought to have the best functional outcomes in language. And this is supported by studies suggesting that right hemisphere recruitment of language areas is associated with worse severity and worse recovery outcomes. And so this has kind of come from the idea that there's mutual inhibition of the two hemispheres when language processing is happening. And so after a stroke, we can have some beneficial uptake of these left hemisphere perilesional areas. But we can also have, because the left hemisphere is damaged and there's less left to right inhibition occurring, we can have some beneficial uptake of the right hemisphere structures. But on the flip side, because the right hemisphere is now relatively disinhibited, we can have overactivity of the right hemisphere causing deleterious increased right to left inhibition, which prevents the uptake of these left hemisphere perilesional areas that are thought to be beneficial for language recovery. And so the idea with TMS is that we can maybe try to rebalance this interhemispheric inhibition and promote left hemisphere language reorganization. So trying to increase the right hemisphere inhibition so that the left hemisphere can heal. And so this is illustrated by this paper where a normal brain, we have mutual inhibition, and after a stroke, we have disinhibition of the right, but we can add TMS to the right hemisphere to increase the inhibitory tone and maybe restore that mutual inhibition. And so neuromodulation of these networks has been quite a hot topic in the field. And so the key modalities that we tend to use are TMS or transcranial direct current stimulation, but we focus on TMS at our lab. And so for those who haven't worked with TMS before, so it's basically an electromagnetic coil that sits on the surface of the scalp, and it delivers very brief but powerful magnetic fields that induce electrical currents of the brain. And if you remember high school physics, that if you put a wire into a magnetic field, it causes a current, and neurons are essentially wires. And when a current goes through the neurons, it causes activation of those neurons. And so you can apply many of these pulses, magnetic pulses in a row, and this is called repetitive transcranial magnetic stimulation, or RTMS. And if we deliver these pulses at specific frequencies, we can induce different types of neuromodulation. And so high frequency stimulation, so something like 20 hertz, so 20 stimulations per second, is thought to be excitatory. We can upregulate activity in the neurons. And low frequency, things like 1 stimulation per second, is thought to be inhibitory. We can downregulate neuronal activity. And so targeting the contralesional side of the brain with 1 hertz inhibitory TMS has been used as a standalone therapy, as well as combined with standard speech language therapy, so something like 30 minutes per day, a few times a week. And it's been generally thought to be beneficial, and several meta-analyses of these small studies and case studies have shown a net benefit of TMS for aphasia. But we kind of wondered whether we get better results with high intensity speech therapy. And then some more recent evidence from Alex Thiel's group up here in Toronto suggested that RTMS plus speech therapy might only be effective at the subacute phase of recovery and not at the chronic phase. So we wondered if we can get a benefit at the chronic stage if we optimize this protocol and offer higher intensity speech therapy. And so this idea of higher intensity speech therapy comes from a few meta-analyses by Marion Brady, suggesting that the greatest aphasia improvements are associated with really high intensity speech therapy multiple days a week, and totaling somewhere between 20 and 50 hours of therapy. And so there's many different protocols that we can use for this. I think there's constraint-induced therapy and a couple others, but we focus on multimodality aphasia therapy developed by Miranda Rose down in Australia. And so this generally follows the same the principles as all the other intensive speech therapy protocols, where we do mass practice. So we looked at over 30 hours within 2 weeks of therapy. And the therapy really focuses on promoting multimodal communication. So whereas in constraint therapy, we only allow people to speak and not write or draw, in multimodality aphasia therapy, we really want people to functionally communicate and get their point across through any means possible. And so we allow people to gesture, draw, write, anything to get their point across during therapy. And the tasks are generally behaviorally relevant in a group setting. So we perform this in groups of 4 to 6. And they're socially relevant tasks. Those things like ordering coffee, ordering from a menu, doing all those kind of daily activities. And so the overall objective of this trial was to assess the efficacy of combining inhibitory TMS over the right hemisphere, combined with 2 weeks intensive therapy of multimodality aphasia therapy versus sham stimulation, so just multimodality aphasia therapy in a chronic aphasia sample. So our study looked at, again, individuals with chronic post-stroke aphasia, so more than 6 months post-stroke. We focused on non-fluent aphasia, and we recruited people from the outpatient clinics here at the Foothills Medical Center, as well as community partners like our community accessible rehab and just aphasia groups in the community as well. And so individuals were randomly allocated in a one-to-one fashion to either receive the inhibitory TMS or sham stimulation, in addition to 35 hours of MMAT over 2 weeks. And again, they were doing this therapy in groups of 4 to 6. So we enrolled people here at the start. We did some baseline speech and language measures, as well as comprehensive like MRI battery. And then for 2 weeks, they did their respective interventions. At week 3, we did speech and MRI again. And then we allowed a follow-up period up to 15 weeks total. So I guess that'll be a 3-month post-treatment where we did the speech batteries again and MRI. And so this is just showing our stimulation targets. We're stimulating the right pars triangularis, which is the right side homologue of Broca's area, right in this triangular shaped gyrus. And so we delivered 1 hertz for 20 minutes at the 100% of their resting motor threshold, which is a pretty standard protocol in the field. In terms of outcome measures, our primary outcome measure was the Western Aphasia Battery Aphasia Quotient. It's an overall measure of aphasia severity. It's pretty widely used. And we were looking for a minimal clinically important difference of 5 points based on some work from Gilmore and colleagues. And our secondary outcome measures include this trained and untrained naming battery. And so during speech therapy, they were using flashcards with images on them. And so those are the trained subset of images that we would assess again at all 3 time points. But we also had a set of images that were withheld from training. And so we called this our untrained set. And they only saw that set at the 3 assessment points. We assessed multimodal communication using the scenario test. So because we were using multimodality aphasia therapy, we thought it was pertinent to understand if their communication was enhanced if we allowed them to gesture, write, or draw during the assessment. And then functional communication using the SETI, and mood and quality of life using the SAGQ and SAQUAL. And these are all part of the Roma 2 consensus on a core outcome set for aphasia interventions. So we, between, what was it, March 2021 and March 2023, we screened 97 individuals from the community and the clinics. We ended up excluding 53 for various reasons. So the biggest reason was that people were too fluent, and then a few people with severe apraxia, and then a large number just decided not to participate. So we used the bedside version of the WOB and the apraxia battery for adults to assess fluency really quickly and then get a good idea of their verbal apraxia. That's where those numbers come from. So ultimately, we randomized 44 individuals pretty evenly, so 22 in each group. We had 1 person in the active treatment withdraw before intervention, so we only had 21 in that group to start, and then we had 1 loss to follow-up in each. So at baseline, our groups are quite even in terms of age, time post-stroke, sex, ethnicity, the proportion of ischemic strokes versus hemorrhagic strokes in terms of lesion volume. Our RTMS group was slightly more fluent on the bedside WOB, but I'll show shortly here that on the WOB AQ that they did not differ. And then in terms of apraxia, they were evenly matched as well. And then in terms of lesion location, they're very evenly matched across groups. There wasn't any significant, or we couldn't appreciate any large differences in the peak lesion location. So in terms of intervention safety, it was very good. Adverse events were very rare and quite mild, which is to be expected with TMS. We did monitor for severe adverse events such as seizures, but we didn't observe any. The common adverse events that we saw were mild headaches at the stimulation site after stimulation, so about 10 in each group across over 200 sessions. And then the other one is like some paresthesias near the target site and in the right upper extremity, but evenly matched across groups. And the total number of adverse events between groups didn't differ. So I guess this is what everyone's probably very interested in. So this is our primary outcome over time, the Western aphasia battery. We used a linear mixed model to model this over time. And so the groups are very evenly matched at baseline. There was a small improvement at 3 weeks between groups that was quite similar. But the real difference that we saw was here at 15 weeks. And I hope that you can see my cursor. Where we saw that the TMS group had significantly greater gains compared to the sham stimulation group. But importantly, both groups overall, we saw about a 5-point increase, which is great to begin with. But to see that the RTMS group had a really delayed but significant benefit of this treatment. And this line is just showing we did some Johnson Neyman testing, which basically tells us where in time the group by time interaction is significant. And so we see that really the statistical significance is later in time rather than immediately after treatment. And so just looking at the raw data, so the change from baseline in WAB-AQ unadjusted, we saw that, again, this was significant at 15 weeks where the RTMS group had greater improvement relative to baseline compared to the sham stimulation group by about 7.5 points, which is quite large for the WAB-AQ. In terms of secondary outcomes, overall we saw improvement on trained and untrained naming, as well as the scenario test in both groups, which is to be expected with our type of intervention and the intensity of the intervention, but there was no significant group by time interaction on these measures. And we also didn't observe any changes on functional communication, quality of life, or mood. So I guess some key points to take away from this is that the study reinforces that high intensity speech therapy is beneficial for chronic post-stroke aphasia. And this has been demonstrated in the literature numerous times by meta-analyses, as well as large trials such as the COMPARE trial and the FCET2EC trial by Brettenstein. And we saw an overall improvement of 5 points on the WAB-AQ at 15 weeks, which is quite large compared to the literature. We typically see after intensive therapy about a 3-point increase on these types of measures. So maybe we're delivering like a high quality intervention, but we're missing some fidelity measures that can verify that. But the most interesting part of the study is that we show that using the inhibitory RTMS with multimodality aphasia therapy results in significantly greater outcomes compared to sham stimulation plus MMAT in the chronic stage. Whereas some prior evidence from the North Star study suggests that there is no benefit of RTMS with speech therapy in the chronic phase, but this might indicate that gains are possible at the chronic phase with this type of intervention, but the protocol needs to have a high dose, a high intensity speech therapy, and perhaps that treatment effects may take longer than 30 days, which is the follow-up time in the North Star study, to appear, which we show our effect was somewhere around 12 weeks and apparent at our 15-week assessment. And it's really encouraging to see that we had delayed but sustained improvements rather than an immediate improvement followed by maintenance of the same baseline over time. But we need a larger trial with longer follow-up to see how long the improvement lasts and kind of where the ceiling is. So in the clinical context, we know that administration of high intensity aphasia interventions is quite costly and resource intensive. And so we hope that by augmenting these types of therapies with TMS, we can facilitate larger long-term improvements. So A, we get more bang for our buck, and two, we can maybe protect our investment. So we get larger improvements for longer with these high intensity programs. But we really need to do a cost analysis to figure out if that's true. So in terms of future directions, we want to do a larger trial, multi-sites with longer follow-up to figure out how long these effects last, if we're seeing a true effect, although our effect size is quite large, and to really see if we can implement this clinically. And so our team is already looking at some qualitative data that we collected to see how caregivers and clinicians have responded to this type of intervention and what their thoughts are on barriers to implementation. And so we've started to develop a toolkit for program delivery, but we also need to do some work looking at what dose of MMAT is absolutely necessary to see if we can reduce the resource requirements of this intervention, and also do some other adaptations of the protocol to be less resource intensive. As you can imagine, doing this 2-week intervention with 4 to 6 people coming through every day, getting brain stimulation plus speech therapy, takes a lot of manpower and a lot of resources. So it might not be pragmatic in the clinical sense. So we need to evaluate that. And then lastly, we collected neuroimaging markers at 3 time points, so functional, diffusion, task-based MRI, plus spectroscopy of metabolites. And so we're hoping to find some neuroimaging markers that might explain the effect that we're seeing with TMS. So just very quickly to acknowledge everyone, so Dr. Sean Duclos is my supervisor, our co-investigators, the numerous lab members and SLPs that made this happen, as well as our funding support. So yeah, that was kind of a rapid fire of this paper, but there was, it was pretty straightforward and a few key points. If you have any further questions about it, you're very welcome to email myself or Dr. Duclos about anything. And with that, I think we'll open it up for discussion.
Sure. Thank you so much. This was really fantastic work. I think we should ask, we have several speech therapists that have joined, and I know they're very busy to come to their lunch hour. So maybe we should open it up to them first in case they can't stay too much longer. I see several on the call. So if anybody has any questions, but I just want to make sure in case our clinicians have to leave soon. Anybody with any questions? Rachel, Lindsay?
I see a hand from Yina.
Yeah, I see Yina. Yina's wonderful. Yeah, she's a wonderful colleague from who's also a speech therapist.
That's right.
Great.
Thank you for your talk. I'm sorry my voice is a little bit off today, but I wanted to ask about effect sizes of anything related to brain stimulation. They seem small to me, and like clinical application of technology like this seems to be far away from the clinic. So I'm just wondering about that, like what is this field moving toward in terms of clinical applications and getting a little bit closer to the clinic?
Yeah, it's a great question because we all want to know how we can implement this into practice and how it's going to help our patients, right? And I think one place to start is that TMS has been approved by the FDA and Health Canada for treatment-resistant depression. So you can access that through various clinics for that indication. And so it's already being used and the machines are out there. But for this context, we're really focusing on, the speech therapists. They already deliver speech therapy, but we're hopeful that maybe we can implement this. We have to do some work in the subacute phase to see how feasible it is, but if we can augment what's already being done in clinic so that essentially the brain is more primed for learning by the time they go to speech therapy, and that they can get better functional outcomes from what's being delivered clinically already. Does that make sense?
Yeah, it does. Thank you.
So Trevor, I was wondering about the lesion size.
Yeah, they're big.
Yeah, they are, which I think is very, when I saw them, it's very impressive. You flip the images, so I'm not used to them.
Yeah, they're in
left versus right.
Mhm.
But yeah, if that is is that the typical size that I mean, I was just wondering what the range of the volumes were of strokes.
Yeah, I didn't give the range, but the deviations are quite large. So we had like a few that were like 10 cc's or something like that, but we had a number that were like 300 like whole hemisphere wipeouts. But yeah, the average is kind of like 100 cc's.
And are you seeing any differences? I mean, I know your samples are a bit small to look on this, but I really wondered if you're still seeing such an effect with the larger strokes.
Yeah, so we really have to dive a little bit deeper into maybe some of our functional imaging to see if these large lesions, if they're truly getting some reactivation of their left hemisphere, or if we're getting some other compensatory, like right hemisphere, like more posteriorly. And so that's kind of what we're exploring. But yeah, on group average, there's not really any difference in lesion size or location. And we're still seeing quite a large effect with TMS.
Okay, yeah, because I think that's fascinating that this could be beneficial for those patients with with large strokes or very
Yeah.
large strokes.
Yeah, and I
And
know there is some debate about like whether or not for very large strokes, if we should be exciting the right hemisphere and kind of just encouraging what's already been reorganized. And so, yeah, it's still something we're exploring and seeing. We have to dig deeper into the data to see if these large lesions we're not seeing an effect, and the effect is largely driven by like the smaller lesions.
yeah, particularly since you were saying, it's the perilesional areas, that may be really important, and you're trying to block inhibition from the right hemisphere. Or is it that there's something else that inhibition from the right side is so strong that that's really what matters more?
Yeah.
I think those are really interesting things to tease apart in your subsequent studies.
Mm-hmm. Definitely. Yeah. So hopefully we can find something, but there's so much noise in the data sometimes it's hard to tease out without a larger sample.
You mentioned about how TMS is approved. It's also approved here, for treatment-resistant depression, but it's certainly not made its way into clinical care. So in general, as you go forward, do you find you have to find some external funding, to do these types of studies?
Yeah, I think we'll have to find some either industry partners or get a very large government grant to do this type of study again. There are a few like private clinics here in Calgary that delivers TMS, and from my understanding, you might be able to get off-label use of it, but it's not really accepted yet. And so it's going to be still a ways out from clinical implementation, I think.
The other thought I had was about, the WOB, how much it's being used clinically. If the speech therapists are using it, in their clinical practice. We have this issue with the Fugl-Meyer of the arm that it really isn't being used. It takes too long, for example. And so, I was thinking about that, like, another challenge when it comes to implementation into clinical practice is the measurements. And so, I was thinking about that. I don't think, at least I can't imagine a WOB being done by anybody but a speech therapist.
Yeah.
So that's
Yeah.
another interesting, translational issue or translational challenge barrier.
Yeah, I guess there's our research outcomes that we prefer to use because they have good reliability, good fidelity. But in practice, I don't think we use it that much at our site either. I think sometimes they use it as a baseline measure. They do it once, but they don't really revisit it. And so maybe in future studies, if you want it to be more pragmatic, including some of what would be typically done in a clinical course and seeing how that relates to improvement. So I see a question about how do we know that the stim is in the exact placement and the site is accurate. So I'll flip back to this figure. And so this is the TMS setup. So this is one of my lab mates. And they sit in this kind of dentist looking chair. You kind of put their head in the stereotaxic frame so it doesn't move too much. And then they're wearing these infrared these balls that can be detected by infrared cameras. And so there's one on the participant and one on the TMS coil. And then we use an infrared camera with neuronavigation software to navigate exactly to the spot on the brain. And we use each person's own MRI image to target that space. And so it's accurate. The software gives us measurements up to the 0.1 of a millimeter.
Hey there, this is Stuart Fraser. I'm a pediatric neurologist. And so would that mean to use TMS, if you're using that software, one of the limits might be the participant has to have a very good, probably a 3 Tesla anatomical image with T1 and T2 beforehand?
It's preferred. They do offer template images that you can kind of register the person's head to and kind of morph it to fit individual heads.
I see.
And so you can kind of calibrate it that way, but definitely preferred to have at least like a 1.5 Tesla. You can use clinical images as well.
Okay. And if they have, a lesion, so the brain anatomy is different from whatever, or would that reduce the accuracy, quote unquote, of the templated images?
I don't think so. What it's really doing is it's reconstructing the skin, so where we can, the very surface level where we're placing the coil. And then second is like it does like a very crude like brain extraction of the image that we do our targeting based off of. And so it's the combination of the skin reconstruction and kind of the surface reconstruction that gives us the targeting. And because we're targeting the non-lesioned hemisphere, it kind of helps mitigate the lesion effect.
Okay, I see. Very cool.
Mm-hmm.
Rachel's questions is so important because I would imagine if the only way this I think would become effective would be with embracement by the speech language pathology community, and so and they're seeing this, and that's a really important question. So what if the stimulation went to a slightly different area of the brain? What's going to happen?
Mm-hmm. Yeah, and I guess we don't really know because we try to keep it as targeted as possible. There have been a couple studies that suggest that stimulation of the pars opercularis, which is slightly more, I believe, post-anterior relative to pars triangularis, that you get a slightly reduced benefit. And so the pars triangularis has a better outcome. And they're only differentiated by like a centimeter or so. So the targeting is very important.
Based on all the data now that you have and just thinking it through, I mean, do you think it's more that the field is more moving in the direction of inhibition on the right hemisphere and less on activation of left hemisphere?
That's definitely the dominant thinking, and there are a few camps that think that activation of the left hemisphere is kind of the way to go. I struggle to think of a study design where you can keep things consistent, because if you're having many different types of strokes and lesions and sizes, then your left hemisphere target moves all the time, right? And so it's hard to compare. But you can also look at it very pragmatically. If you're stimulating like the highest activation site on the left hemisphere, localized by task fMRI, for example, and you keep that consistent, then maybe you can compare. But for, I think, ease of targeting and stuff like that, people tend to navigate to the right side.
I see.
Well, I think, so it's as I said, we just think it's fascinating what you're finding. It's you're in these earlier stages where it's still very much in a research setting, and we think a lot about how you translate into clinical practice. And I see you've got there's a lot of steps ahead, because my sense is that a lot of the community of clinicians that take care of the patients with aphasia don't really know much about this approach.
Exactly.
Which is why we're trying to have this type of venue to ask our colleagues and our clinicians to come and see what's cutting edge that may be coming.
Yeah, and it's helpful for me to see kind of what questions like our SLP colleagues have. We work very closely with our inpatient SLPs up here in Calgary to develop this protocol, and so they have a bit of understanding of what's going on, but they still have some questions about how they would implement this in a clinical sense. Especially if we want to look at earlier time points like the subacute phase. This might be better done in this type of high intensity. Is probably really easy or relatively easy to do in an outpatient setting for chronic aphasia, but when you have like a subacute, like inpatient clinical service, I can imagine we don't have time or resources to do this.
Yeah, right. Because you have that limited amount of time that the therapist has with the patient. Where would this fit? Seems unlikely it's going to be within that hour that they have, or is it a separate session? So there's going to be some interesting things that will come in the future if your subsequent work and other colleagues that are working in this area, really definitively show in phase 3 trials that this is having that type of effect size. Seems pretty significant.
Mm-hmm.
Yeah. What can I ask? I sometimes I wonder, what are those things that we've talked about them, but you also see might get in the way of adoption of more TMS. And this comes with the caveat that a couple of your co-authors are on my mentorship committee, and Adam Curtin did a trial in kids for cerebral palsy with TMS. It had some pretty positive results, but not definitive in 2016. And then he kind of stopped, and he actually told me a few years ago, as I was trying to do this, to be careful about TMS in kids, particularly because of tolerability and getting it done. What sort of stuff do you see? I mean, you obviously got to work with adults. I'm sure were motivated, which is great. What kind of things got in the way of sort of doing this quickly and in a tolerable way? I mean, it looked like the tolerability results were great. I'm just wondering sort of what you see from your perspective.
Yeah, working with adults is definitely much easier, and these folks had pretty like profound aphasia, so they're willing to sit through anything.
Okay.
And I think the fact that a lot of them also had some like hemipresis or hemiplegia, they couldn't really sense what was feeling like on the right side of their head, so the tolerability was good. I tested the protocol myself before we ran anyone, and it's brutal. Like you have this thing blasting your right like temporalis muscle that's like not very comfortable. But depending on your resting motor threshold, that could be a bit more tolerable as well. And the timing, it was quite a lot. So we did 20 minutes of 1 hertz. And so when you're trying to coordinate multiple people all getting TMS before speech therapy and then getting to them to speech therapy at the relative same time, the 20 minutes was quite a hindrance. So I think just TMS takes a long time. Like with theta pers now, we can maybe do this protocol like in a much shorter time period.
Yeah.
I think theta bursts like you can do in like a minute or something like that.
Mm.
And so I think Adam's moved to TDCS primarily because it's more tolerable, and you can also do it while the therapy is occurring. You don't need like a separate session to do TMS and then go to the therapy. And
Yeah.
the units are just much smaller and cheaper and easier to maneuver.
Yeah, but of course, there have been, over the past couple of months, there have been 2 publications of negative trials for arm rehabilitation for TDCS. One was Dr. Curtin's, and then the other one was in adults. So it's one of those things where, like, well, yes, it's much more tolerable, but is it doing anything, or is it doing what we think it's doing? Yeah, obviously I'm asking impossible questions, but
Yeah.
TMS is an interesting field. It just has, some technical stuff that obviously we have to work out.
Yeah, and I definitely appreciate with TMS that you have an exact location that you're stimulating, and we have a pretty good idea of like what the physiology of what is going on under that coil.
Yeah,
based on motor studies. So I think there's a lot of unanswered questions with TDCS as well.
Yeah, fascinating.
Yeah, I'm just wondering whether, the data just seems like it's going in for TCDS, it looks like it's going in the direction of that where, in more definitive randomized studies, we're not seeing an effect.
Right.
And, TMS, your paper comes out and it's starting to make me think, TMS, there's more data supporting TMS.
Yeah.
Yeah, definitely.
Yeah, fascinating. That is so cool.
Yeah, thank you.
Yeah, well, so we definitely look forward to your next subsequent analysis, to see, which ones may be more benefiting than others.
Yeah, so we'll have some imaging data come out hopefully soon. I'm really the only one working on it right now, so it's hard to find time in medical school to do that. But we also have some qualitative studies coming out talking about the experiences of the participants and kind of what they saw as benefits and barriers.
Okay, I think that'll be helpful. We're especially as the field, they may sort of be talking about this a bit in med school, but lately I've been hearing a lot about the suggestion that we should be thinking about, even before we prove something works, we should be thinking a little bit about how would this be implemented, which I think Dr. Savitz and everyone else was already bringing up. And so I think that's really good that you're already thinking about those qualitative experiences, because if you get some positive results, the same issue, like, okay, who and how could we get this to someone? And we should really probably add in some of those thoughts as you make your bigger, more definitive trials going forward. So I look forward to that. Obviously, we're rooting for you guys. We want something to work.
Yeah, we appreciate the support. Yeah.
Just anything. I don't care.
Yeah, and all these questions are super helpful to kind of help guide like my future questions. But yeah, we're hoping that we can use the imaging to find some markers that kind of support what's going on here, or we can use it to better select patients for future trials, things like that. So
very cool.
This is great. Does anybody else have any other questions? Just wanted to say, thank you to the audience. We have colleagues from Turkey, from Egypt as well that joined. So thank you so much, because we know that it's pretty late in those countries. But just so you know, Trevor, we've even got, colleagues that are working in computer engineering from UT Austin. And so I think, you're clearly, what you're studying, I think, is of great importance across different fields. So I think I'm hoping there'll be more synergy as time goes on, where, people are thinking from different perspectives on how to improve the outcomes of these patients with aphasia.
Definitely. Yeah, we definitely need to look at it from more than one way to kind of find more answers.
Great. Okay. All right. If
Awesome.
no other questions, then we'll stop here. And again, thank you so much. Really interesting.
Yeah, thanks so much for inviting me. It was a pleasure.
Good luck. Thanks, guys.
Take care.